This is the subject that I addressed in my opening remarks about how we transform our public mental health system and even our private insurance-based mental health system from prevention and early intervention, or from fail first to prevention and early intervention. And maybe we ought to start with Joel here. If you'd be willing to share briefly your story and what might have been different early in your life that would have changed what you have lived through.
Okay, so good evening, everyone. And it's a very complex issue, and I think it involves a lot more than just, we don't have a silver bullet for this, but I grew up just 10 minutes away from here. I was sharing with him earlier that I come from immigrant parents. Both my parents only had a 6th grade education. They were very limited. My problems begin at home, come from alcoholic family, domestic violence. By the age of 17, when I committed my crime, I had 19 of my friends murdered because of gang violence. So I grew up in an environment that was very heavily involved with gang violence, drug dealing. And what could have helped? I mean, I came home from school. I was bused to the Valley. It was a new program. For us, it was a pilot program to get a better education, and I was overwhelmed. I wasn't ready for that. So I felt very disempowered. I felt that I was never going to amount to anything. I couldn't come home and ask my parents for help because they were limited. And so I looked outside the neighborhood and I saw these men who were very empowered, and I wanted that because I couldn't get it through my education. I couldn't get it at home. And so could I say that my family failed me? Well, they did what they could. My community failed me? Well, it was a broken community. Was my institution of education failed me? Well, I guess that played a factor as well, but I don't know. It takes a lot more than just, we don't have a silver bullet. I think it involves everyone.
Everyone. Thank you. So, Judge, you run a mental health court in Los Angeles County, correct?
Yes.
Could you give us just a little bit of perspective, please, in this regard? A 3-part question. How many mental health courts are there in LA County? Approximately what percentage of people who come through the criminal courts who would be eligible and needing a mental health intervention actually get the mental health court referral? And third, do you have sufficient resources to refer people to so that they can get the help that they need?
So those are great questions. I'll actually answer the third one first. The answer is absolutely emphatically no. We've got way less treatment available than we need. And that's from my perspective as a judge in the mental health court. So I could put hundreds more people into treatment, and instead, they're stuck in county jail. County jail has become the bed that never says no. So there needs to be way more treatment available than there is. And I don't want to be completely negative about it, because I think this is a moment in time, and this is an opportunity to try to turn the ship around. And I think Dr. Sharon is really sort of leading that charge. In terms of, let's see, the first
number of mental health courts and what percentage of people who could use the mental health intervention actually get referred to mental health court.
So in Los Angeles, there are, let's say, roughly 550 judges. So each judge has a courtroom. There are probably about 250 of those are criminal courtrooms. And there are 4 courtrooms that are mental health courtrooms. So I run one of the mental health courtrooms. So there are 4 courts is the answer to your question, but really, I think every judge that's involved with a criminal caseload in some way is a mental health court judge, because, I'll just give you the numbers. There are somewhere in the 16 to 17,000 range of people in county jail right now in Los Angeles County. 5,000 of those 16 or 17,000 have a mental illness. So there's no way that the mental health courts could even begin to deal with the scale of need. So what we really get in the mental health court are the people that are the sickest. So people that need court intervention on the civil side for conservatorships, things like that, and people who are charged with crimes but are doing so poorly that they're incompetent to stand trial. That's.
So I'm going to ask John Boyd a question in a minute, but I have one follow-up for you, which is, as you review the voluminous court records and the history of the people who come through your court, is there sort of a common element of a point in time, much earlier, where a mental health identification and intervention might have prevented that individual from ever showing up in your court?
It's actually a great question.
Good question. Thank you.
You know, what I can tell you is, so I talked about people who are incompetent to stand trial. And I'll narrow that down to people charged with misdemeanors. So we have people that are in county jail that are being treated there to try to get them better, who are charged with things like trespass. And this might be a homeless person who's sleeping in a parking garage and picks up multiple charges for that offense, and then is stuck in county jail for no reason other than the fact that they're incompetent. Now, when we started moving people into community treatment, and we've got a pretty good program going, although, again, we don't have as much treatment as we need, they started looking at their county MIS hits, and people would have encountered the county mental health system 90 times. So what I see from where I sit is that people have this tendency to sort of fall off a cliff, right? So for instance, we get people into this really great community treatment. We try to really encourage them to engage in the treatment, but at some point the court case ends. If that person can then stay in that treatment, but if they decide, I want to walk away, the door closes behind them. And then it's not until there's some other intervention, either an involuntary hospitalization or probably more likely another arrest, that they get their way back into the system.
Thank you. So John Boyd, you play many roles in the mental health world, a real leader here and a friend of mine. You're the Chief Executive Officer for Mental Health for Sutter Health. And you also chair this Prop 63 Oversight and Accountability Commission, essentially overseeing what's amounting to over $500 million of prevention, early intervention, and innovation dollars. From your perspective, is there a statewide strategy for how to deploy these resources in a way that would be most impactful to the issues we're discussing here today?
I think I would lead probably with saying that I'm going to respond based from two different perspectives. The first being the one that you just referenced, and the second would be my own experience of what was effective as a child and as an adolescent. Regarding statewide perspective, the success of Prop 63 dollars are very significant, but we have much work to be done. A couple of efforts that we're doing currently is we're focusing on mental health innovation specific to young people. I want to applaud LA County for taking a lead in helping design technology suite dollars and doing the things that it's going to take to effectively engage those young people. But we have more work to be done. I'm sitting here next to a colleague here to my left. And the truth of the matter is many of my own experiences as a child and adolescent probably more align with his than many of the people I go to work with every day. And so I stop and I think, what is effective? What are the real conversations we need to have? I think one of the real conversations we need to have is the opportunities that we actually have both in terms of our schools and our faith communities, frankly. When I look back on what would have made a difference and what made a difference in my life, it was those two areas. It was a speech teacher that happened to notice I was a new student, probably going to my 8th school by the time I was in the 4th grade, and it was the faith community. But I've got to be honest, Daryl, I think it's these kind of conversations that we need to have that's involving young people themselves that's going to help us design the solutions we're looking for. And we all have room to grow and stretch, so I'm just going to be transparent. We have to be honest about the kinds of traumas and experiences that are impacting kids. Those of us that grew up in significant poverty might happen to identify with a minority situation, whether it's LGBT or ethnic minority. Our faith communities could use additional support, I believe, on how to engage with all young people so that there is no social prejudice that actually becomes a barrier for treatment. So we're doing a lot on the state level. I think we know what works to some extent. I think we need to do it.
Thank you. Thank you, John. I want to ask Joel, but maybe for all of you, about the issues of cultural competency and cultural humility, because mental health and treatment for mental health means very different things to different people in different communities. When you think, Joel, you're from a community of color, when you hear the words mental health as it applies to even your own life experience or your community, what do you think? Is it something that sort of scares you a little bit? Are there ways that we need to understand how to make mental health care more accessible in terms of accepting help in our various communities? How do you look at that issue?
Absolutely. This is not a black or a brown issue. This is a human issue.
And of course it is.
And I strongly believe that, someone like myself, there's a strong correlation with that. The cycle of trauma starts at the very beginning when you're a child. And it's hard. Think about it. The minute the cuffs are put on a child, that traumatizes you. The violence that we experience not only at home in our communities, but we get re-socialized in prison, like as a 17-year-old, to be with men. And again, so this notion of exile, you get uprooted from your community, you get uprooted from your family, you get uprooted and you go into a place where you're isolated and humiliated. That doesn't fix anything. So it's sad, but mental health is even abused by inmates, by COs, just by everyone. And I think that, it should aspire empathy, and that, we're all broken in a sense. So in that regard, I think that there is a strong correlation, and I think that it's going to take, all of us to be part of this movement, to be part of this call. In ARC, we focus on, a strong network of mentors. We also focus on opportunities like with education and providing jobs, but another aspect is also to empower us, to be part of the solution. And I think that we all have a responsibility. We all have a stake at this.
And Judge, what about you in terms of cultural competency? Do judges get trained in terms of cultural stigma around mental health? Are your referrals different, modalities different, sometimes depending upon the community that somebody comes from in terms of a referral? How does that work?
We do get training in that area, and I think I see perhaps some different cultures, there might be a greater degree of shame, but I think that sort of barrier cuts across most, if not all, cultures. I don't see some cultures that are doing really well and sort of helping the people in their community that have mental illness. I think it's a problem across all cultures that I see in court.
Yeah. And John Boyd, I want to ask you, from your vantage point of your role with Sutter, about the predominance of not only jails but emergency rooms in our mental health care. It's pretty well known that emergency rooms are overrun with people in psychiatric crisis, and that emergency rooms are unable to kind of keep up with the load. What is Sutter Health doing? What is the state doing through the Prop 63 to try to change the paradigm around the emergency room being, the police in the emergency room being who you call if your loved one is in crisis?
So a few of the things we're doing, frankly, is partnering with the efforts that we've talked about, some of which include the Steinberg Institute in terms of participating in the policy dialogue and advocacy dialogue for California and for young people. The second is the role that SB 82 funding has afforded for us, which really brings about $30 million throughout California every year, in which there are peers and people with lived experience in jail settings and homeless shelters and the emergency rooms. So figuring out more appropriately what works. The other thing is taking very strong steps to be transparent amongst our own workforce, to eliminate social prejudice and discrimination amongst those that have mental health conditions. You should be able to go to every healthcare touch point and be treated with dignity, respect, and that should be an access point to the rest of the system of care. Our emergency rooms, unfortunately, are no different than a lot of care settings, which is you go there at most 24 hours, probably not designed in a way that you even want to access care or service, which isn't just unique to the emergency room. It's found embedded in other of our care kind of settings. But really looking at how do we capture that life that's with us and ensure that we've treated them like we would want our own mother, brother, sister, brother to be treated, understand what's happening, strengthen community-based resources and infrastructure so they never get into the emergency room in the first place.
I'm going to follow up with you and go down the line here again, John, which is, what is the role of, or what should be the role of the primary care physician or the pediatrician in identifying that a child needs help, and at what age?
Yeah. So absolutely. I mean, this whole dissection in which we have tried to separate the brain and mental health from the body, that whole paradigm needs to strongly shift and change. If you are a pediatrician, a primary care provider, your responsibility is to the whole person. Pediatricians are uniquely focused to do universal screening, to figure out what's going on with the family, to align resources and support. So absolutely, the pediatrician and primary care providers, transforming that environment, making sure they have resources and tools, is how I believe we're going to significantly shift what we're talking about today.
Good, thank you. Joel, I think the audience who doesn't know anything about the Anti-Recidivism Coalition, 60 seconds here, sir. What is the Anti-Recidivism Coalition? Because I know what it is and the profound work that you and your colleagues are doing throughout California, but please share with everybody.
Yeah, the Anti-Recidivism Coalition is a member-driven organization of men and women who were formerly incarcerated and who are part of this movement to help our, we would say, our brothers, our errant brothers who are coming back and reintegrating society. And so, you know, we're there for them. And I think it, again, you know, it goes to, when you redeem others, you're redeeming yourself. And I think it goes along with also this call for us to look at our fellow brother and our fellow human being and to help in whatever capacity we can.
And we'll give the last word to the judge here with this question, because we're down to 30 seconds here. And that is, while judges obviously are not allowed to engage in partisan politics, they are allowed to speak out clearly on issues to improve the administration of justice. And so if you could change the justice system around mental health and mental illness in one way, what would you say? What do you advocate for?
So I could give you 20 or 30 ways to change it, but you said one, so I'll stick to one. 2 words, more treatment. I think if judges had the ability to steer people towards treatment, whether it's through a diversion program, whether it's through competency restoration, whether it's through a conservatorship, whatever it is, give us more treatment, and I think we can be a much better partner in the whole scheme.
Thank you very much, panelists, for a great panel. Within time, it was short, but it was very good and very, very thorough. Great, great job. Thank you. Thank you all very much.